we go ahead and get started? Good evening, everyone. Happy Tuesday in this a beautiful Tuesday evening of March 15th, payday for some of us. So a good day. It's good to see everyone, those of you who have joined us or chose to spend your evening with us, and it's been a little bit since we've seen each other. Let's just have a quick word of prayer real quick, and then we'll jump right into it. Most gracious and kind Father, we thank you again for the blessing of congregating and sharing, and for mostly your love and patience with each one of us. We ask now that you be with us over the next moments as I try to share what you've given to me, and pray that it is received and then shared again. Be with all of us, help us to be present and available. Amen. Okay, so today I'm not going to talk about COVID, believe it or not. If folk want to ask COVID questions, we can talk about that. There's lots of COVID stuff kind of going on, but since there's no real pandemic, a lot of that's really just associated with taking your mask off or being able to take your mask off and walk into a store. And there are new variants, but they're not variants of concern. And Omicron seems to have kind of swept through, and people are sort of lost their appetite for this pandemic stuff and trying to get back to normal. But there's still some things kind of going on, still lingering questions, issues around vaccines and whether you should get a third or a fourth or a fifth and all of that. And so I am happy to answer those sorts of questions a little later if folk want to. However, tonight, what I want to talk a little bit about is something I don't think I have ever talked about before, but it's related to this broader topic of information. And I thought that it might be a motivating reason for there to be a large audience and participation when I talk about what I think is one of the foundations to disease and health, which is inflammation. So tonight I'm going to talk about cancer and cancer prevention. And the reason why I'm going to talk about cancer, let me just start sharing my screen now, is because during the pandemic, it is very clear by a lot of our stats that in fact, people stop going to the doctor, stop being adherent to a lot of their sort of routine visits and checkups, etc. People and doctors were not connecting. They were not laying hands on each other. People were more distracted by the inconveniences of life, more frustrated in their homes and their relationships and their jobs, and not paying attention to some of the things that are sort of going on in the background. And so for many people, that means that they have either delayed or skipped completely their requisite cancer screening. And so tonight, I just wanted to spend a few moments putting that in context and reminding each of us, because many of us on this call are old enough all to be in that cancer screening group, that this is something that we should be on top of. And if we've delayed it for any reason, we should get right back to it. This is one area where prevention and screening in our healthcare system really does work. So I wanted to spend some time on that. And then probably the next time we're just going to use cancer and cancer as an issue, but there are many other chronic diseases, as a reason to really get people interested in inflammation. Because I believe, as well as so many others, that if we can really control and have an understanding of the things we do to contribute to chronic and insidious inflammation in our bodies, and what contributes to that and control that, we can actually prevent many of the chronic diseases. And one of the most common chronic diseases that leads to death is cancer, and heart disease, and many of the other sort of chronic indolent diseases as well. So with that, let me first just start off with some stats, some statistics, right? There in the United States this year, it's sort of estimated that of the 400 million folk or so that live in the US, 2 million of them will have a new cancer. Now, that doesn't include the millions, probably more than 70 to 80 million, who already have a diagnosis of cancer. So new cancer, about 1 million new males and about 1 million new females, most adults, but obviously some children, will develop a new cancer. And what you see here on this slide is just which cancers are the most prevalent. And in men, prostate cancer, and in women, breast cancer are the most common new cancers that we see, followed by lung and colon for both men and women. And so this is really, really important because it really means that this is going to be a challenge to think about how we kind of curb these new diseases that continue to pop up. And what I'm going to show you next is just a little data as it relates to how it's broken down by age, by sex, and even by racial ethnic groups. And so what you can see over time, over the last about 45 years or so, if you compare this to 1975, and again, this is corrected per the population per 100,000, even though we had some peaks, probably in the early 1990s, sort of peaks, we sort of have leveled off, and one could argue that the incidence of cancer over the last 45 years or so hasn't changed that much, right? These fancy graphs, whether you're male or female, people are still developing cancer. And this is really important because this means that even though we are doing, recommending screening, we have lots of new data and new techniques, et cetera, the incidence of cancer hasn't changed. Now, this may be conflated a little bit because we actually, at the rate we're decreasing cancer, new cancers, people may be more compliant with cancer screening. And so it sort of cancels each other off. We don't know that for a fact, but that's what people think, that actually we're just picking up cancers because people are getting more screening, even though the sort of rates may be lower in the population. And again, there's no way to tell that. But just looking at this tells me we still actually have a lot to do. When you look at just sort of trends in men, obviously prostate cancer is the largest and probably is what is sort of leading the sort of ongoing trend across time. You do see colorectal cancer and lung cancer rates going down. Lung cancer rates are actually going down overall, and most middle-aged and older adults because they've stopped smoking. Even prior smokers have said, we're going to stop smoking. But young people, actually, even though it's not represented here because they are such a small proportion of the population of people with lung cancer, are increasing for the first time ever in the last 10 years in new lung cancer. So that's actually very, very important. Similar for women, you can see that breast cancer proportionally, right, is still the largest new cancer rate in females. And again, how much of this is because there's actually new cancers versus we actually are picking up new cancers because of screening is hard to know. Well, even though we look at and we like to slice information up by race from time to time, race is sometimes very crude because oftentimes just the ethnic group or race and ethnic group by itself doesn't tell the story. And so if you looked at the new cancer rates by race alone, non-Hispanic whites, you could see there compared to blacks, it's very similar. And you would say that if you just looked at this data alone, that there doesn't seem to be a huge disparity between blacks and whites in terms of new cancers. But that doesn't tell the disparity story. And in fact, you can look at disparity in a lot of ways. You can look at it with regard to geography. And so, for example, if you are an African American or Hispanic woman or male, for that matter, and you live in a rural environment, rural area compared to folk who live in a more urbanized setting. So you just take all rural living people and you take rural living Blacks and Hispanic versus rural living whites. Rural living Blacks and Hispanics are much more likely to have poorer outcomes from their disease. We know disparities are propagated by differences in insurance rates and access between Black and brown communities compared to their white counterparts. Disparities are propagated because of education level, right, and awareness of cancer between Black and brown folk and their white counterparts, right? So it's not just as simple as saying Black or white. There are lots of sort of what we call social determinants of health or other conditions, which actually really add or define the disparity. In addition to that, the way the healthcare system reacts to you is different. So if you are a Black man and you have prostate cancer, as an example, and you are a white male and you have prostate cancer, all things being equal, the survival rate of the Black male compared to the white male is less. Everything being equal, okay? Education, access and insurance, etc. The white male will have a better chance of survival than the Black male. And this is true for a lot of diseases, not just cancer. It's true for heart disease. It's true for diabetes. It's true for a lot of things. The way our healthcare system in the United States treats underrepresented folk, quite frankly, there's no other explanation, biases the care that's managed and delivered by our healthcare providers and systems. So what you really want to do is not get yourself in the situation where you need management in the first place, right? What you really want to do is prevent it. So what are the lifetime probabilities of cancer in men and women? This slide actually just shows the lifetime chance of developing various cancers for men. All sites, if you're a male, 1 in 2 male men are going to have some diagnosis of cancer in their lifetime. Okay, that means 50%. 50%. Now, I haven't gone back to the Zoom call, so I don't know how many men, but at the time that I went to slides, about half the folk on the slides were men, about half were women. I think I counted 4 or 5. And, you know, I won't name any names, but, you know, that's 4 or 5 of us, right? And out of the 4 or 5, that's 2 of us having one of these cancers, right? If you just play at the odds. Now, we're going to get a little bit of protection, protection because we all are doing the right things. We're faithful, and we're eating right, and we're exercising, etc. But it doesn't reduce this risk to non-existent, right? And so we may, with really sort of doing all the right things, reduce our all-time risk from 1 in 2 to maybe 1 in 5. Which is actually quite impressive, like really a dramatic risk reduction. But still, the lifetime risk of developing a cancer, if you're a male, is actually quite high. The most common one that will be developed, as I said before, is prostate cancer, and that number is 1 in 8, and probably a little bit higher than that if you separate different populations. So for a Black male, it might be closer to just under 1 in 7. Lung cancer, you see 1 in 16, colon cancer, 1 in 24. And again, there are differences for brown and Black folk where that number might be closer to 1 in 18 or 1 in 20. Okay, so very important to look at these chances. And if this doesn't get your attention, I'm not sure what will. For females, you can see they have a slightly lower risk of all type cancer than men, but still, just like prostate cancer, that 1 in 8, 1 in 7, 1 in 8 number comes up. And again, Black females, African Americans are higher, African American women are higher likely to actually have a lifetime probability compared to their non-African American, non-Hispanic white counterparts, right? So that number is probably closer to 1 in 7 or just under 1 in 7. Okay. Any questions about this? And again, my job isn't to depress anybody. It's actually to motivate you that, in fact, these are realities that we can kind of take into our sort of consciousness to motivate us, right? To sort of change our behaviors and change what we do. Now, this is, I think, really important. This looks at just survival rates. And this is some of the good news is that if you look at the 1970s versus the 1990s versus recent decade, the chances of survival, if you get a diagnosis of cancer 5 years after your diagnosis, has improved quite a bit for a variety of diagnoses. Particularly prostate cancer, if you look there at the bottom, right? Prostate cancer in the 70s, 68%, versus in the 90s, virtually, if you get diagnosed with prostate cancer, we have pretty good treatment for that. But that's a 5-year survival. As you get towards 10 and 15-year survivals, those numbers drop off. And what's happening is many of these cancers we're diagnosing early. And if we're diagnosing these cancers earlier, like in our 40s or our 50s, and people could live to 75 or 80, the survival rate, the lifetime survival rate, if you will, isn't as high. You can see that breast cancer has improved over time. Colorectal cancer, and this is one of the key points I want you all to remember, the colorectal cancer rates have actually only improved a little bit. The best treatment for colorectal cancer is actually getting your colonoscopy, getting polyps or suspicious polyps removed before they actually become cancerous. And so once someone is diagnosed with colorectal cancer, even though there are some effective therapies, our therapies and our advances in therapies have not changed dramatically the survival once the cancer is developed and active. Similarly for lung cancer, that's the case as well. So again, for some diseases, there have been dramatic improvements in therapy, but for many, there have only been mild or moderate improvements, even with all of our technology, all of our research, all our investment. So again, just to underscore, it's so important to be thinking about how we prevent the diseases in the first place. And one of the keys to prevention is changing our risk for our bodies even developing it. But beyond that, it's actually adhering to some of the cancer screening protocols. Okay. This is by race, and this underscores what I was saying before. And it's not all simply just a race issue, because a lot of this has to do with some of the social determinants of health, access, the way folk are treated based on just their appearance, education level, social conditions, etc. And you can see that for almost every cancer, okay, that's listed here, there is an absolute worse outcome, survival outcome, for Blacks, African Americans compared to non-Hispanic whites. Some it's just small, but others it's actually quite significant. Okay. All right, and the distribution when it comes to death is slightly different, even though prostate and breast are the most common that you will get, or from a new cancer, people are much more likely when they get something to die from lung cancer, whether you're a male or female. And lung cancer is one of the types of cancers which we actually have had probably the least advancement of therapy, and we have some of the probably the least effective screening tools for that. This is just, again, some data say that by slides, if you're just looking at overall numbers, death rates seem to be actually going down. And again, the way this is defined is per population. And so, yes, things have actually improved to some degree. But again, if you look at females and just looked at the line, for example, that line is around 160 per 100,000 in 1975. And this line now is around 140 per 100,000. So it's less, but I would argue not dramatically less. For men, things are certainly much better. And a big part of that improvement for men, this delta, is because of prostate cancer. I will skip the slide. This just talks about the number of people who would have died had we not sort of changed things, treatment and access and screening over the last 20 years. Okay, so when we think about, again, death rates, as I told you, lung cancer, both for men and women, are the leading causes of death. But again, here's for men. If you look at colorectal cancer and prostate cancer, when we just look back, 25 or 30 years, things look a lot better. The reason why I love this slide is because what's hidden in this slide is looking back even further. Okay, and when you look back to the 1930s, things increased quite a bit. And you have to ask yourself, what happened in the 1930s to the 1950s, right? What really changed and actually increased the risk of prostate cancer and colorectal cancer, right? And some of those things have to do with our nutrition, diet, our industrialization, so environmental exposures, and smoking. Okay? And so while things actually look like they're getting a lot better over the last 25, 30 years, in truth, they're just coming back down to what they were at the beginning of the 20th century. What we're doing finally is trying to undo, or at least come up with mitigating strategies for a lot of the things that we actually put in our environment or put in our habits or our behaviors. Okay? So I think that's always a very interesting slide. Whenever I see the slide, people always pay attention and talk about this, but I think it's so important to look at sort of the pre-peak. If you look at actually lung cancer, was practically unheard of. Very small numbers of people have lung cancer, but that exploded, right, as industrialization and smoking took hold. So I think it's very, very important to let us know that cancer is something that society and populations and people have contributed significantly to. It's not just there in the background waiting as some defect, but in fact, a lot of it's actually external and environmentally induced. And you can see very similar sort of trends for women as well. Here are the rates of death. And again, even though they may seem similar, non-Hispanic Blacks, for example, men, again, all things being equal, will die at a higher rate than their white, non-Hispanic white male counterparts. And the same thing for non-Hispanic Black females than their non-Hispanic white counterparts. And again, those subtle differences have to do mostly with the determinants of health, as we talked about, educational differences, access difference, et cetera, but also the way the health system treats and responds to people coming in for care. I'll skip that slide. So let me ask folk just sort of the magic question, okay, and I want you to reflect on it. What cancers do we have extremely good evidence that we should actively participate in screening? Okay, just think about that for a second. You can talk that to yourself. And as you think about that to yourself, what I want you all to do, you don't have to say it out loud, please don't. Ask yourself, have you actually complied to those same cancer screening recommendations for which you're saying, definitely we should be screening for this, there's a guideline to screen for that, okay? So just take a moment and reflect. What data, what evidence, what guidelines do we have really good evidence that we should screen for? And then, what actually have you undergone screening for? Okay, so I'm going to go through them real quick, okay? Skin cancer, no question, is one of the most common cancers. Now, people don't die from it, it's fairly rare, but it can be quite morbid. And even though many of us have a degree or more of melanin deposits to protect us, it does not mean that us melanin or sort of pigment endowed individuals aren't at risk for skin cancer. Skin cancer and skin damage and soil damage can occur for everybody. Melanoma, squamous cell carcinoma of the skin, and basal cell carcinoma of the skin. And so checking your skin, that's something that we can all do. If you actually see something on your skin that's new or different or changing rapidly or is associated with any sort of discomfort or pain, you should absolutely get that evaluated. Okay, it's that simple. Colorectal screening. Does anyone know what the recommendations are for colorectal cancer screening? You can unmute and volunteer. And there should be so many people here who've already had their colorectal cancer screening.
Every
After
10
the
years.
age of 50.
And after
the age of 50.
Okay, I'm hearing after the age of 50 and then every 10 years. Well, it turns out that that's not quite right. Okay, so it depends on, first off, the first question is if you have any family members who have a history of colorectal cancer. If you have family members with a history of colorectal cancer, then regardless of their age, if someone is younger, right, a younger individual, you take 10 years younger than their diagnosis of colorectal cancer. And that's when you should begin as a family member, right? So if you take a first or second degree relative and they have colorectal cancer, then you subtract the age, the time that they were diagnosed by 10 years. And that's when you start, if it's before the age of 45. So it used to be 50, Jackie. The new age is 45. You begin general colorectal cancer screening at age 45. Now, it is yearly if you decide to take a what we call a fecal occult blood test. So you're just using a stool sample looking for blood. That's an annual test, okay? And if that's positive, there's a procedure for that. If you take a flexible sigmoidoscopy, it's every 5 years. And if you do a full colorectal screening with a colonoscopy, it's every 10 years. And those are if the tests come back normal. If the tests come back abnormal, they find some sorts of polyps, etc., that might actually decrease your interval of screening. So for example, if I have a colonoscopy, in the colonoscopy, they find 2 polyps, and these polyps actually are benign, but they actually are multiple and they have certain shapes. They might ask me to come back and get a colonoscopy again in 1 to 2 years or 3 to 5 years. It depends on the pathology. So just because you had a colonoscopy and they say they did not find cancer, if they find polyps or something, it is very likely that even if those polyps were benign, that they're going to tell you to come back sooner than 10 years. So please pay attention when you have your colorectal cancer screening to the specific recommendations. Okay, just because they say there's no cancer doesn't mean you get a 10-year buy. You may want a 10-year buy, but in fact, if they find polyps or other abnormalities, you may need to come back sooner. Now, I put colorectal cancer and skin cancer up here at the highest, because if you screen and find something precancerous, even early cancer, that's at a very early level, particularly polyps, etc., or these localized skin lesions, you can actually cure the potential of cancer by the treatment of the lesion that's being screened for, right? So if you have what we call actinic keratosis, which is a precancerous lesion, treating that on the skin prevents you from developing basal cell carcinoma. It's that simple. Similarly, colorectal cancer, almost all colorectal cancer starts from a polyp, okay? And most of those polyps start out benign and they degenerate over time. So if I find a polyp and I'm doing your colonoscopy and I remove that polyp, I've just prevented that polyp from becoming a colon cancer. So the first admonishment is anyone on this phone, I think everyone on this phone that I saw early on was 45 years of age and older. I think so. Everyone on this phone, on this call, on the sound of my voice, should absolutely have a colonoscopy. And I would actually prefer a colonoscopy over actually fecal occult blood testing, yearly fecal occult blood testing every day. The data for that's better. And fecal occult blood testing doesn't, by doing the test, cure you of anything. Versus colonoscopy, if you have your colonoscopy and they see a polyp and they take it out, they can cure you before it even becomes a problem. So let me let that sink in. Everyone listening should be doing skin surveys. If you can't see your back, have your spouse or partner or someone look at your back. But everyone should be looking at their skin. Everyone should be getting a colonoscopy. No excuses, no questions. Okay? Let me pause there before I go on and ask, does anyone have any questions about what I just said about colonoscopy? That's good. That's outstanding. So let's talk about breast cancer screening. Breast cancer screening is actually very interesting. And I know I have a couple of women's health practitioners here, so they should be able to answer these questions perfectly. So what are the current guidelines for breast cancer screening? Anyone want to take a risk?
Average age starts at 40, but if you have a first generation family history, you should start it earlier.
Okay. Andy, you want to take a stab at that?
I was actually going to say something similar. I know that they had moved a lot of screening to 50, but I know I had my first screening at 35. So I kind of would concur with Jackie.
Yeah, so breast cancer screening is one of those where it depends on which guideline you want to follow, okay? Because there are a number of different guidelines that are available. But in general, and there's some controversy and conflicts between guidelines, but in general, most people agree that women should start self-screening with palpation in the shower or when their skin is wet at earliest age as 30 or 35 years of age. Okay, particularly for our African American women who typically have earlier onset disease and more severe onset disease. Okay, so most people agree and support early screening, and meaning women becoming familiar with their breasts in the shower or bath, so that women, turns out that patients and women are more likely to diagnose themselves with a new lump or abnormality than their doctor, okay, by a long shot. So the earlier a female is familiar with and gets used to evaluating and examining their breasts, again, in the shower or bath, starting as early as 30 or 35, and that the more likely that they will self-diagnose with a subtle change, either in tissue or the recognition of a lump or abnormality. And so self-examination in the 30s, be it 30 or 35, is recommended by almost all groups. Now, when it comes to actual mammography, there are different types of mammography that can be done. There's sort of MIBI, assisted mammography, MRIs, there's all such stuff. But basic mammography, now, again, there's controversy whether you start at 35, whether you start at 40, 45, or 50. And a lot of it has to do with the particular guideline and how they define patients at risk. And in general, what I would say, strongly encourage, is that African American women, in general, have worse outcomes than their counterparts. And when they get diagnosed, have higher stage, when they're screened and diagnosed, have a higher stage disease. And that's owed to a lot of different variables. Some of that we've already talked about before, that may be associated with the population, could be associated with education, our healthcare system, access and insurance, but also breast density and anatomy comes into play as well. And so there's a lot of controversy about starting early, but more people and more guidelines are actually beginning to recommend, depending on the guideline, starting breast cancer screening as early as 35, particularly if there's a first degree relative with a history of breast cancer, right? Or 40. And 40 in general for everyone, with some pushback from insurance companies and payers, I'm just going to tell you, to move that, as Jackie said, towards 50. So you have some HMOs that actually are saying, no, not unless you're high risk, you have to wait till you're 50. But there are very good, I think, thoughtful cancer guidelines that consistently say, unless you have a first degree relative with a history of breast cancer, that you should start breast cancer screening at age 40. Any questions about breast cancer screening? And again, I think I would ask the women on the line, it's cancer screening, and then there's continued follow-up. So you start at whatever time you start, be it 40 or 45, then it's actually being consistent with every 1 to 2 years, depending on the finding. So
Darrell,
you may have
I have
had
a question. Oh,
yeah. Go ahead.
no, I was going to say, for those, say they begin their screening at 40 or 35, depending on their risk levels. If density, if their breast is discovered as being dense, because I know that that's an issue where sometimes you can't really be definitive in your, I guess, saying that it's a completely benign mammography. And so I'm just asking, because I know sometimes that generates more screening. It's a little inconclusive.
Yeah, so this is the question that you're asking is actually also the same question that gets asked for prostate cancer screening, right? Which is you get screened and you have a inconclusive or ambiguous result. And that ambiguous or inconclusive result could be for a variety of reasons. In the case that you're talking about, breast density, or it might just be the actual radiographic finding itself, right? And so what do you do? And always the decision is, cancer screening decisions should always be made collaboratively, right? Collaboratively between the patient and the doctor. Never the doctor just saying like, oh, don't worry about it. You should always be informed, right? If something is abnormal, it's abnormal for a reason. And it may be abnormal because it's not a big deal, but you'd like to understand that or at least have some input in that. In general, for breast cancer, when breast cancer comes back as sort of dense breast, not sure. Well, on the one hand, women might say having dense breasts is a good thing, or their partner might say having dense breasts is a good thing. I'm sort of joking a little bit, just to lighten things up. But having said that, really then you have to go back to your risk, right? And risk assessment. And so you have two choices, right? You have a choice to just simply repeat a mammogram in an interval of time of 1-2 years, or to get more advanced testing, which includes radiographic imaging or genetic testing. So let me talk about that real quickly, right? If you're a high risk, let me finish real quick.
Okay,
let me finish real quick. So if you are high risk, meaning you have multiple family members, first and second degree relatives who have breast cancer, then one of the things that can be done that we can do now that we didn't do before is that we can now do genetic testing. And the genetic testing can help inform how aggressive to pursue radiographic imaging, right? So that's something we didn't have before, and that's something that you would make as a decision collaboratively with your physician. Simply just going down additional tests without sort of a plan, as Andy suggested, is not a good idea because you could end up with more information, more confusion, and still no answer. So always asking the question when you come up with an ambiguous screening test for breast cancer or prostate cancer, it's like, what are the next steps? What will I do differently if that test comes back positive or negative? Then what? And ask that question 3 times. 3 times. And when you feel comfortable with the answer to those different questions, each of those 3 stages, then you can proceed. And if not, you might need to talk to somebody else. Go ahead. There was someone else who had a question.
Yes, my name is Brenda, and I have
Hi,
a
Brenda.
question. Hi, Dr. Harrington. I'm Marcus' cousin, so I just want to, thank Marcus and as well as you for holding this forum for us, because I do have a very important question regarding breast cancer.
Sure.
I heard it's maternal versus paternal.
Mm-hmm.
But so is that the, are there any exceptions to that rule, or, is it only your mother you can, receive breast cancer from?
Yeah, so that's a great question. Usually we talk about breast cancer, we talk about breast cancer in women, but men do have a non-insignificant risk of developing breast cancer. So, but we don't screen for it. There are no real screening policies or guidelines for screening for breast cancer for men because it's just not frequent enough. But actually, it does occur. So this is what you're referring to and what people talk about. In general, there is a genetic, in most cancers, there are genetic risk factors, if you will, that get transmitted from family members, right, from generation to generation, and that explains a proportion, not all of, but a proportion of the risk of cancer. Now, with breast cancer and uterine cancer, for example, there are a proportion of high-risk cancers, which if your mother had it or an aunt had it, for example, and they had a certain genetic cancer type, the chances that gets passed on to another female or male, okay, this is where the male or female comes from, so it can get passed on to anybody. That risk gets passed on is very high. Likewise, a male, it doesn't guarantee that you're going to get it, but it increases your risk substantially, right? And we talk about the BRCA gene, right, as one of the sort of genetic, genetic markers attached to breast cancer, and it's passed down from generation to generation. It doesn't guarantee. So, say for example, my mother, who had breast cancer, she had breast cancer at an early point before they were doing all this testing. But let's just say that she got tested and she had the genetic marker BRCA. Well, she has 2 daughters and two sons. Because she has BRCA, it doesn't mean that her 2 daughters or her 2 sons are going to 100% get breast cancer. No, but it does mean that her 2 daughters for sure should start getting screened earlier. And if there's something that's abnormal, it should be looked at much more seriously, right? Does that make sense?
Yes.
And that if one of her sons, like myself, if I found something abnormal in my chest or breast tissue, that I would take it very seriously. Everything I said about a mother having a genetically oriented breast cancer being passed down to the children, right?
Yes.
Actually also applies to a man who has breast cancer, who happens to have a breast cancer type that's genetically, right, sort of loaded. If a man has breast cancer, which is very uncommon, And when they do that diagnosis, that breast cancer turns out to be a breast cancer that has a genetic attribute attached to that,
Yes.
then the offspring of that man, both daughters and sons, have a higher risk of breast cancer. Again, not doomed to get it, but a higher risk.
Darrell, I
Did that
wanted to
answer your question?
clarify.
Yeah.
Yes, I was just wondering, is it possible to receive that genetic marker from a father versus a mother?
Yes. So it is. Usually those men have to have breast cancer themselves, but that cancer gene. So I'll go back to my example. Say my mother had BRCA. She had the gene. Okay.
Yes.
And that gene could be passed down to me as a male. Okay.
Okay.
And as a male, I could pass that gene down to my offspring.
I see. Okay.
Even if I don't have breast cancer. Even if I don't have breast cancer.
Okay. All right.
I think
so
that
much.
sometimes a concern is a paternal aunt having breast cancer, and I don't know if that's what you were saying, but if a paternal aunt or grandmother had a breast cancer, is that as higher risk as, say, the mother or maternal aunt or maternal grandmother?
Yeah. So thanks for clarifying that. Maternal transmission is stronger than paternal transmission. Okay. Period. But paternal transmission from women in the genetic lineage directly attached to that male is absolutely possible. The risk is much lower, but it's absolutely possible.
Okay.
Right?
Yes.
It's not high enough unless there are lots of people, right, on that side that we would change the screening protocol for their daughter. So, for example, if it's my great grandmother, right, or a second generation aunt, we wouldn't do anything different for my daughter. Okay. However, if it's my mother, right, or my grandmother, so my mother and my grandmother have it, and my wife's side is completely clean. No one's had breast cancer. My daughter should actually be considered at a higher risk, right, than someone without a father who had so much breast cancer in his history. Okay, so yes, having a paternal risk lineage, so of a father, for example, who's had multiple people on that side with breast cancer, that breast cancer gene can be passed through the father to the children.
Okay. Do we need to consider going back centuries to
No. And I think Andy knows this well. Usually we count 2 generations, so parent and grandparent, and then you look at first and second degree relatives, and then it's the number of people, right? So you have first cousins and second cousins. You have your mom, or in this case, sort of like your parents' generation, and then the direct grandparents, right? And that's sort of it. And you look at any one of those or multiples of those that actually is associated with risk. But you do not need to go back. Like if those.
Sorry,
that's all right. So if your immediate parents, first degree relatives, and your grandparents do not have known symptomatic breast cancer, you do not need to go back further than that. Okay. It's a good question.
Dr. D, what percentage of breast cancer is actually linked to genetics? And I ask this because of the 12 women that I know who have had breast cancer, only one had a relative who had breast cancer, and it happened to be her aunt. And I think that many times women, we tell ourselves, well, I don't have a first degree relative that has breast cancer, therefore I don't need to be as concerned about my screenings. So
Yeah, so that's a hard question, right? If you just said what we traditionally describe as hereditary, right? Like restate the question differently, but the same is like, what percent of breast cancer is strictly defined as hereditary, right? Probably somewhere around 1 in 10, around 10%, right? 90% isn't. But it's a complicated question, Vina, because we're learning more about genetics every day, right? So, 25 years ago, we didn't know enough about genetics to even come up with that 10%. You understand what I'm saying? So, 10 years from now, that number of 10% may be 20% or maybe 30% because we're going to learn more about genetics and genetic testing. Having said that, your point is the right one for all of these diseases, right? Family history or not, even though as a doctor, we always take family history when we're talking to patients about, diabetes and about cancer and about heart disease and all this other stuff. The reality is as you get older, you saw the numbers. I mean, I showed you the numbers earlier, right? 1 in 2 men are going to have some sort of cancer in general. 1 in 3 women are going to have some cancer in general. The top 3 cancers on the board are breast, lung, and colorectal, or prostate, lung, and colorectal for men. So just playing the numbers game, even if you have no one related to you whatsoever who has any cancer at all, part of the reason why I'm bringing this up tonight, is because we've had a hiatus in thinking about ourselves and cancer prevention and screening, et cetera. And a lot of the other things that we should be doing for wellness that are really evidence-based, that can be curative and preventative. And cancer is one of them. I just looked at some data late last week, and that's why I decided to talk about this. In our hospital system, where the compliance with cancer screening during the last 2 years dropped like by 50%, okay? Just because of COVID, okay? People scared to come out, et cetera, et cetera. So, Vina, your point is so important that even if you don't have a hereditary risk, even if you don't have a known person in your family with colorectal cancer, breast cancer, prostate cancer, whatever it is, even though people talk about a hereditary component, the hereditary proportion is still a small proportion of those cancers, at least as we know right now. And so everyone who's got a colon should get their colon screened. Everyone who has breasts, 1 or 2, who were born with those breasts, who are women or identify as women born with those breasts, let me be politically correct, should have them screened, right? Prostate should be screened, particularly for Black men. There's like no question about it, right? And that's regardless of whether you have anyone in the family who has a history of cancer, because the majority of new cancer that's being diagnosed is being diagnosed in people without a strong family history for all of these cancers. So I appreciate you bringing that up, Vina. I think the point about in the conversation around hereditary cancer should come into play when we begin thinking about how aggressive we should be with screening and treatment beyond the usual guidelines. Okay, so when you have hereditary risk factors, that just actually sort of steps up the game, if you will, of screening, if that makes sense.
Could I say something, Dr. Harrington? That is so true, because I had cancer in the eye 10 years ago, and no one in my family that I've never even heard of that. And I just went to the eye doctor and I had a lesion, and come to find out it was actually cancer. So we don't have a family history of it or anything like that. And, it was pretty scary, but we got through it and everything. But
Yeah.
it was, so that's so important for screening or any lesions or anything that anyone sees. I would say definitely go get it checked, because I thought with my eye, I was like, oh, it's not a big deal. And I ended up being in the hospital for, a week or so. And it turned out to be a huge deal. And so now if
Yeah.
someone walks to the left of me, I have no full vision because they had to remove some of the muscle and that kind of thing out of my eye. But it is definitely important, because you just don't know. And we did not have any history of it, like absolutely not. And as far as genetics, I love the genetic doctor, because our son has Feingold syndrome, and it is a Jewish disease or genetic disorder. And no one in my family has it, nor Leonard's family. So it's so important, because when you see things, you do have to just go, because it could be the first. So I know I was the first.
Yeah, it's so important. The points you're making are really important. It's just, again, a reminder to everybody that very few diseases, including cancer, have a single hit. Most things are caused because of a variety of risk, attributable risk, right? We talk about environment, and we talk about nutrition and diet. We talk about mental health and well-being and the stress that plays, and genetics, right? And a lot of the things, again, the reason why I'm talking about this so much is because the next time we talk, we're going to talk about inflammation. And a lot of those risks and all of those things that we talk about actually come to the cancer plate via chronic inflammation. So I'll come back to that when we talk just about inflammation and how we can actually sort of decrease our inflammation in our daily lives. But I'll finish the cancer discussion. So some really good questions about breast cancer. Let's not forget the brothers here. Prostate cancer. When do we start getting our prostates screened? Gentlemen, anyone? And everyone, all males on this call should have already had their prostate cancer screening. So when is this supposed to start?
At age 50?
So it used to be age 50. They reduced it to the general public to 45. And there are a variety of advocates who are saying for Black men, it should start at 40. Okay. So the accepted American Cancer Society guideline now says 45 to start. And again, for Black men, there's a big push to start 5 years earlier at 40. Now, again, prostate cancer screening is sort of twofold. One part of that actually includes a digital rectal exam, which no one is happy about, right? What I take that back. Most people aren't happy about. And then a blood test called a prostate-specific antigen, or PSA. A lot of doctors are just ordering the PSA and not even doing the digital rectal exam, which is not appropriate. Really, it should be done together. But anyway, the PSA is very, very important. And the one thing I want to say about PSA, even though they have these ranges of normal, 0 to 4 is normal range, 4 to 10 is sort of suspicious, and greater than 10 is actually really, really scary. It's not that simple. If you are young and say 35 years of age or 40 years of age, you really should have a PSA level which is almost nearly undetectable. Okay? Point something, not 1 point something, like point something. As we get older, our prostates get larger. And so the amount of PSA that's just sitting there, it should be higher, right? So as a 60-year-old man, my PSA might be 2.0, but as a 40-year-old man, my prostate specific antigen or PSA should be 0.2. Okay, so as you get older, your PSA levels will go up because your prostate gland is larger. Okay, What's important for prostate screening with the PSA is the rate of change in your PSA level over time. So for Black men, again, this is the way the health system actually takes care of us, which is not great. I am 45 years of age and I get a PSA and my PSA is 0.2. I then go back, say 4 years later or 3 years later, they do a PSA and my PSA is 3. Both numbers are in the normal range, but going from 0.2 as a baseline to 3 in 3 years is abnormally high. And that needs to be investigated. So lots of details. It's not just the number itself. It's not just being in the normal range itself. It's actually understanding even changes within some of the screening that you undergo annually that are actually important. All right, any questions about prostate? Start early. Brothers on this line, everyone should have had the PSA already. People should know what the PSA is by heart and keep track of your PSA for sure. Okay. All right. Uterine and cervical cancer screening. What's the new guidelines for uterine and cervical cancer screening? Andy and Joette, if you guys don't get this, I'm going to come through the phone.
Jackie will answer, not Joette. 21.
I'm sorry, Jackie. Okay.
21, you get cervical culture testing. And it's every 3 years under the age of 30. After age 30, if they've all been normal, every 5 years. But at any time, if it becomes abnormal, you're supposed to be tested. And if it's like the HPV and the Pap is abnormal, then you may get additional testing, like to take a part of the tissue and send it for real cancer screening. And that's called a colposcopy.
I like that. Andy, do you agree with that?
I do.
Then,
and in terms of uterine screening or cancer, we do endometrial biopsies, preferably over ultrasounds. If there's any suspicious bleeding for our women who are 35 years of age and older or who have high risk issues.
Yeah.
So, Darrell, but at 65, they usually stop doing cervical cancer, cervical testing.
So the 65 and older stopping thing is going to be changed soon because life expectancy is changing, right? So as life expectancy goes up and quality of life goes up, then the idea of having that in the guidelines before was that why test for something that they won't outlive if you make a diagnosis, right? But now that you have people living pretty good qualities of life in their 80s, and I can tell you this, particularly for folk with resources, they continue to get screened despite the guidelines. So I guarantee you the guidelines are going to change, and it's going to be a discussion based on, quite frankly, are you still sexually active?
Exactly.
And are you sexually active, and what's your quality of life over time, right? So very good. I give you guys both A's for that.
But Darrell,
and
I have one more point to make with that. HPV vaccines, they should be given to both male and females, and that's something that is really important to prevent HPV virus.
Yeah, you stole my thunder. Thank you, Jackie.
I'm sorry. Which is human papillomavirus.
Yeah. So what Jackie's referring to for our young men and young women, that penile cancer as well as cervical cancer, there is a large proportion of those cancers which are etiologically directly related to a chronic infection called HPV or human papillomavirus. That chronic infection usually is asymptomatic and wears a smiley face, right? When you're dating. And so no one knows who's got HPV, right? No one knows. You're just happy. And by the way, birth control, particularly barrier protections like condoms, do not prevent HPV, right? So a male can pass it to women, and women can pass it to men, or boys and girls, okay? So the recommendation, the strong recommendation, is that this is a vaccine which is not just preventative, but truly curative of a cancer that never has to exist, right? And what we're already seeing in our cancer statistics is a large drop off in cervical cancer and penile related cancers for men because of HPV vaccine. So it's a sort of a no-brainer. There's a number of series you have to take, but it's a sort of a no-brainer for young men and women.
Well, excuse me, Dr. Harrington. How is it contacted? How is it contacted if if you can't prevent it by using a condom? How do we attain that virus?
Well, so that's a really good question, and I won't be too graphical. But what I will say is that the same action where you are using that condom is the same action that transmits it. So just remember that a condom as a barrier, number one, protects, is only effective for the things it's effective with if you use a condom properly. That's number one, right? Because many people are think about using a condom to prevent pregnancy, right? So there's a lot of skin action going on, right? And then they just say, okay, it might be getting close. Let me go ahead and put a condom on so that you don't get pregnant. Well, you've already been in contact, right? And in tissues, been contacted and infected. So that's number one. The inappropriate use of a condom is responsible for a lot of disease transmission. Now, even with proper use of a condom, let me finish. Even with proper use of a condom, before intercourse even begins, okay? So you put on the condom appropriately, you wear it perfectly. The condom actually is not designed to protect against very small particles, okay? So very small particles like HPV, which is a very tiny particle, can still easily be transmitted through the condom and around the condom itself. So, and that's the same action. And I will say, and I'll just have to say it because you've asked the question. It's not just vaginal intercourse, right? Any sort of contact with the genitalia, the anal rectal area, or the mouth can transfer lots of the diseases that we're talking about, particularly HPV as well as herpes, right?
Okay.
And can I add? I mean, and I don't know how you would put a condom on without using your hands. And for some males, they have some forms of HPV, may not be associated with a lot of the cervical cancers, but they put it on with their hand, they could be putting the HPV right on the condom.
See, now you're getting more graphical, Andy. But let's just say
spell it out.
I appreciate that. Let's just say this: HPV is one of these viruses that can live and survive in a lot of places and thrive. Your mouth, your hands. People have warts, right? For example, even if you don't have a visible wart, HPV can be on your hands. And even on other parts of your body, your elbow, believe it or not, right? So you could people get quite creative, right, in that sort of activity. But HPV can be transmitted very easily from wherever it lives to the target tissue. And so what Andy is suggesting, more graphically, is absolutely correct, right? And so the real prevention when it comes to male-related penile cancer and cervical cancer is just preventing yourself from even getting infected in the first place. And the vaccine is, virtually 99% effective at preventing infection if you comply with the series of the vaccine appropriately for both men and women.
So what age should a woman or man stop having the HPV? You know, that test,
the vaccine or the or screening for it.
the screening for it, or the vaccine. Mainly the vaccine.
Yeah. So vaccines. If you are already past your teenage years and you're sexually active, in the, sort of in the dating world, one could strongly argue that both men and women should go ahead and get vaccinated. Okay, just go ahead and get vaccinated, whatever age you are. If you're non-monogamous and you're in the dating world, there's an argument to be made. Get vaccinated. If we're talking about sort of prospectively, okay, teenage boys, young men, boys, and young girls should be vaccinated. Okay, and that's because of the reality that it's a chronic infection, number one, and number two, the reality is that a lot of our young people. This is a whole different topic. I don't want to go down that path, but a lot of our young people are sexually active, even if it's not intercourse, as Andy suggested. They're experimenting or exploring in other ways, right?
Yes.
Sometimes at a very young age, and there's also this ugly reality of, molestation, right? So I don't want to kind of go down that dark path, but I just wanted to make that clear.
If I'm 66 and sexually active, I should be screening and testing for that, or getting vaccinated for that.
Yes, I mean, so the guidelines will say no. They'll say stop at 65, and there's controversy about it. But and so what I'm saying is that if you are a Kaiser patient or someone with HMO or whatever, they may tell you our guidelines say you're 66, you don't need this, don't do it. What I would tell you, if you're 66 and you're still out in the dating population, okay, dating a variety of folk and sexually active, and you're in good health, let me repeat that, you're in good health. There's no reason why you're not going to live to your 80 or 85. Absolutely. I would test you. I would continue to screen you for your uterine/cervical cancer. Absolutely. Okay.
Thank you.
That's yeah. Go ahead.
I just have one question. Maybe Kaiser's HMO. So I know we give the vaccine for HPV up until age 45, and that recently, maybe in the last few years, changed. We used to give it up to age 26. But now they've extended it to 45. I don't know if that's what everybody else is doing.
This is exactly what I'm telling you. Like the guidelines change because people wake up to the reality that not everyone over 50 stops having sex, right? Or not everyone, at 35 and married is, monogamous. And so as people wake up to the reality of the behaviors in the population, you will see that both with longevity and just sort of the diagnosis, right? You're going to continue to be making diagnoses of cervical cancer in a woman who is 62 years of age, has been married for 32 years. Okay?
Yes.
And so someone's going to say, we could have actually done something potentially for that woman. We don't know when she got it, right? Maybe she actually got it when she was 45 from her husband, right? Who got it from someplace else. So there's some real consequences of like human behavior attached to, the recommendations. But again, like so many things, it's actually about, is it cost effective or not? All right, so let me keep going. I just have a couple more, and we've been going at what I thought was going to be a pretty straightforward conversation, but we've had some really good questions and comments, so I really appreciate that. Oral cavity and throat, so your mouth and throat. I can't tell you, this is one of the most sad anatomical areas to have cancer. Almost always it's squamous cell carcinoma, almost always associated with tobacco use or chewing snuff. It could also be associated with trauma, and chronic inflammation of oral hygiene. And so the point is that just like your skin, you see your mouth and you open your mouth every day. If you've got a growth or something that's different, or a discoloration in your mouth that's different, go see your dentist. Okay, your dentist will always do screening for oral cancer. That's part of their training. But not everyone goes to the dentist every year or every 6 months, right? So that's something that you can do looking in the mirror. And the last thing there is lung cancer. The reason why I put question marks there is because the guidelines keep changing about lung cancer. We know if you're someone who's actually a heavy secondhand smoker, or you yourself have a history of recent smoking or current smoking, that's a group that's high risk that should be screened for lung cancer with high resolution CT. If you are a remote smoker and you have not smoked for 20 years and you're asymptomatic, you have no chronic lung disease like COPD, or you haven't really had much in the way of secondhand smoke from a partner or a housemate, for example, then the benefits of lung cancer screening with high-risk CT have gone way down, and it becomes cost ineffective. So even though lung cancer is the number one cause of cancer death, it turns out to have the least evidence for screening in the general population. So if you've got COPD, if you're a heavy smoker, for example, be the first hand or second hand, then you get a screen. But otherwise, no need to kind of screen for that. Okay.
Yeah, I have
Yeah.
a quick question regarding that. You know, with a lot of people using marijuana now, I know vaping is probably just as bad as regular smoking, but people using marijuana, they don't think it's going to cause lung cancer. But is that tendency higher now since it's legal? And a lot of people are thinking it's nothing to worry about.
Yeah, so that's a really good question. We don't have enough data yet about vaping. We do have a lot of data about marijuana, right? People who are marijuana users smoke marijuana because there are a lot of different ways to use marijuana, right? So let's just talk about smoking marijuana. We have pretty good data from decades that if you only smoke marijuana, but you didn't smoke tobacco or cigarettes, that your risk of lung cancer was no different than the general population. Okay, so that data we already have. But that's because most people who smoke marijuana recreationally don't smoke that much. So it doesn't mean that the inhalation of the smoke from marijuana isn't healthy for your lungs. It just means that in general, the majority of people who smoke marijuana recreationally don't smoke it frequently enough for the pollutants of the inhalant or the smoke to cause damage. Okay, so we know that. With regard to vaping, which is a different beast completely, we don't have enough data yet because we know that vaping, that people, depending on what's in the vaping, that people actually, from a puff standpoint of view, actually vape more and inhale more than they do when smoking a cigarette. So if you actually have a cigarette and that's burning in between your fingers, it turns out that many people are attached to the cigarette just hanging between their fingers, their index and middle finger, and it's just burning than inhaling, right? They might actually take, 10 to 15 drags total on that cigarette. And then that may be it for the next, 5 hours, 6 hours to another break. Versus vaping, you'll see people sometimes vape continually, right? Over time. So we don't have data yet on vaping. People are looking for that to see what harm it causes with regard to cancer. And the two cancers that would be most likely, or the three most likely would be oral cavity or gastrointestinal. So those two, and then lung, right? But we don't have an update on that yet. So really good question. Okay, so again, just a reminder, the lifetime risk for men and women is actually quite high, okay? And so what we should be thinking about, again, is if you're in the sound of my voice and you have not had colorectal cancer screening, go get it, okay? Just go get it. If you haven't looked at your skin, look at it and have someone else look at your back. If you haven't looked at your mouth, open it and look at it, okay? Or go to the dentist. For breast cancer and for uterine cervical cancer screening and prostate cancer,